I mean, I think we've heard today the importance of MASLD and the rising importance, which we probably are underestimating. So I'm going to give an overview of MASLD in Africa, but then also look at the GNC Global Consensus recommendations on MASLD and MASH. This is a brief outline of my talk. So as we know, steatotic liver disease is the umbrella term for describing conditions where there's abnormal accumulation of lipid within the liver and is diagnosed either histologically or by imaging. And we know that actually there are three main components: the MASLD, where we really want to distinguish between steatosis, and MASH with the risk of fibrosis and cirrhosis. But increasingly important, I think, in clinical practice is the condition of MASLD, which is a combination of MASLD and alcohol. So here you're looking at, for women, between 20 to 50 grams a day, and for men, 30 to 60 grams a day, and then alcohol-associated liver disease. So as we've heard in a number of talks, MASLD is defined as the presence of hepatic steatosis in conjunction with one or more cardiometabolic risk factors and no other discernible cause. But importantly, alcohol is allowed, provided it's less than 20 grams a day or less than 30 grams a day for men. And I think that's what we realistically see in our real-life clinics. In terms of MASLD, it's important to recognize that there's really a continuum across the spectrum, which can vary in patient over time. And importantly, multiple etiologies of steatosis now can coexist, so you can have MASLD plus autoimmune hepatitis, or MASLD plus viral hepatitis, once more reflecting the real-life clinic situation that we deal with. So as we know, it's the leading global cause of chronic liver disease, affects approximately 38% of the world's population, or 1.7 billion individuals, with the highest prevalences in Kuwait, Egypt, and Qatar. The global MASH prevalence is about just over 5%, and MASH prevalence in MASLD patients at 16%. And as we've seen repeatedly, the main drivers of MASLD are obesity and type 2 diabetes. So if we look at the at-risk populations for MASLD, that's particularly when we're dealing at primary and secondary healthcare, we need to understand men are slightly more than females until you actually develop in the postmenopausal period, where that risk increases in female. 55% of your BMI is greater than 30, 66% of individuals with type 2 diabetes, 74% of those with metabolic syndrome, and 90% if you have more than or equal to class 2 obesity. And then just remember, if you have multiple cardiometabolic risk factors, this increases your risk. So this was the Global Burden of Disease study from 2010 to 2021. And in 2021, the highest age standard point prevalence rates of MASLD per 100,000 population were in North Africa and the Middle East at 27,686 cases per 100,000 population, followed by Central Latin America and Tropical Latin America. But if we dive down into Africa, in fact, Sudan within Africa had the largest increase in age standardized point prevalence estimates at just over 13%. So just importantly, looking at that MASLD distribution according to sex, males were more than females across all regions and including in sub-Saharan and North Africa. The peak age prevalence differed between sexes, was between 45 to 49 for men, and for women between 50 to 54, probably reflecting the increased prevalence as you develop the postmenopause. So as we know, the prevalence and incidence rates of MASLD are closely related to modern dietary patterns with increased intake of ultra-processed and calorie-dense foods, decreased physical activity, and rapid urbanization. And this is associated with this increasing prevalence of the main drivers of obesity and type 2 diabetes. And importantly, the SDI levels actually affect the incidence, where they peak at the moderate SDI intervals. And here you can see on the graph on the right, Western, Central, and Eastern have a low SDI, low prevalence. Southern Sub-Saharan Africa, moderate. And then you see this disproportional prevalence in North Africa and the Middle East. This is once again coming from the Global Burden of Disease study in 2021, where they looked at the age standardized prevalence rates, incidence rates, and years lost to disability across the different regions. And you can see there in yellow, North Africa and the Middle East accounts for the increase significant for both age standardized prevalence, incidence, and years lost to disability, with the lowest prevalence rates being in Central Sub-Saharan Africa. So then if we dive down looking at the cardiometabolic factors that actually are what their prevalence is within Africa, if we look at the metabolic syndrome, this is above 30%, in fact, across all the regions, it is highest in Southern Africa at 33.6%. In terms of type 2 diabetes, the age standardized prevalence per 100,000 population, highest in the MENA region at 9,288, and lowest in East Africa at 2,900. And then in terms of the obesity prevalence, as not as unexpected, in the MENA region, it was 77.7% prevalence in females and 70% in males. But I think quite concerning, if we look in Southern Africa, 71% of females and 45% of males. We've heard these figures before. Between 2017 and 2045, Africa is projected to experience the highest relative increase worldwide in diabetes, with the number of adults of all types of diabetes predicted to increase from 16 to 41 million, which is a 156% increase. And then importantly, this association of food insecurity with MASLD prevalence and liver-related mortality. This is a study on your left which looked at liver-related mortality across 204 countries, and it estimated globally to be 2.92 per 100,000, in Sub-Saharan Africa 2.34, and in North Africa and the Middle East at 1.56. And liver-related mortality due to MASLD was associated with older age, obesity, and metabolic risks. On the right, what you'll see here is with the high SDI countries, the higher MASLD prevalence here is linked to food security, but the food insecurity here is related to the consumption of low-quality, ultra-processed foods. In the low SDI countries, food insecurity tends to lead to malnutrition and often a lower MASLD prevalence. So what is the importance of diagnosing and risk stratifying for MASLD? Well, we know this is a high all-cause and liver-related morbidity and mortality, and we need to risk stratify those at risk that need to be moved into tertiary care. It's important that we develop diagnostic strategies and pathways of referral for risk MASLD and manage the extrahepatic manifestations, with active management of the associated non-communicable diseases, with type 2 diabetes and obesity having the strongest impact on the natural history, with progression to MASLD or MASH-related advanced fibrosis, cirrhosis, and HCC. So bearing in mind, there's been a number of guidance documents that have been developed to help clinicians care for people with MASLD and MASH. Most of the recommendations are concordant, but however, there are areas of discordance that could cause confusion, particularly at primary or secondary care level. So the GNC looked at a study of 61 global MASH guidelines, guidance documents, and civil publications, and actually determined there were 46 areas of discordance. There were 4 rounds of the Delphi process, which established consensus recommendations for MASLD screening, risk stratification, and treatment. And the aim was really to streamline and simplify recommendations, developing a summary document for ease of implementation of the recommendations into clinical practice, but also importantly provide infographics in terms of lifestyle management and drugs that are preferred for the treatment of comorbidities in patients with MASLD. So if we look at the Delphi panel, the steering committee consisted of 32, and in terms of the population from which the panel was drawn, this was 190 global NASH Council members. And if we looked at the data that was actually derived from looking at all these guidance documents, we looked at prevalence, we looked at incidence. And I think importantly, if we look at the lean prevalence of MASLD in the general population, it was between 5 to 7%. But there was a difference depending on where you were in the world. So 20% in the Western and Eastern hemispheres and 40% in the Eastern. F1 to F2 prevalence in the general population ranged between 7 to 8%, and F3 to F4, 1 to 2%. With the incidence of MASLD being between 48.8 to 50 per 1,000 person years. As we've seen, all-cause mortality is significant, 12.6 to 7 per 1,000 person years. Cardiac-specific mortality ranging between 4 to 5.5, and extrahepatic cancer mortality would be 2.8 to 4.2 per 1,000 person years, and then a liver-specific mortality between 0.9 to 1.7. So just importantly, we've heard about the increasing problem of obesity amongst children, and we looked at the 61 guidelines, only 65% mentioned the pediatric populations, and only 55% provided any recommendations. If we looked at screening and diagnosis, 55% provided risk factors to consider for screening for MASLD, 23% listed diagnostic criteria, and 55% suggested liver biopsy if there was an increased risk for advanced liver disease and advanced fibrosis. In terms of the therapeutic interventions, 41% prefers screening and treatment of other risk factors such as diabetes and obesity, and 73% suggested diet and exercise as the main treatment interventions. But of interest, really, I think, is 59% discussed bariatric surgery considerations. So looking at the sort of infographics that were developed from the global consensus recommendations, so your risk factors if you had type 2 diabetes, or you had obesity with one additional cardiometabolic risk factor, or chronically elevated transaminases with no other cause, then you look at the FIB4. It was greater than 1.3 or greater than 2 for the age of 6.5. You have a high probability of being at risk, and here you need to move to a second-line test, and we've heard about the ELF test, and here we've looked at the FibroScan. If the FibroScan was actually available outside hepatology or GI services, this could be done, and if the FibroScan and the liver stiffness was greater than 8, these individuals should be referred to hepatology or GI services. If you're unable to do that FibroScan at secondary level, then you'd refer directly to more tertiary care services. And then once again, if you FibroScan, the liver stiffness is less than 8, here you can remain in primary care, and you can repeat this every 1 to 3 years, depending on the clinical condition and how well you've actually controlled those comorbidities that are driving MASLD. I think this is a very useful pictographic looking at screening for MASLD-associated liver cancer. So if cirrhosis is present, you will screen all patients as is recommended every 6 months with lifelong screening with liver ultrasound and an alpha-fetoprotein. And if necessary, you will need to go on to other imaging such as CT scan and MRI, depending on a case-to-case basis. But if you don't have cirrhosis, you look and see individually, are they at risk of developing cirrhosis or HCC in the absence of cirrhosis? So the high-risk profiles have identified the presence of comorbidities, diabetes and obesity, family history of liver cancer, older age, alcohol intake, and increased fibrosis marker. And then on a case-by-case basis, you will decide on the need to screen every 6 months for HCC. And then the lifestyle recommendations for individuals with MASLD. So we looked at weight loss, and here you get advice is given in the infographic in terms of if you have MASLD and you're overweight or obesity, or MASLD and a normal weight. The diet recommendations, the Mediterranean diet, but importantly, advice regarding limitation of ultra-processed foods, saturated fats, and avoidance of sugar-sweetened beverages. In fact, studies from sub-Saharan Africa showed we have one of the highest intake of these sugar-sweetened beverages. Advice is given regarding exercise, daily exercise in terms of being moderate, 150 to 300 minutes a week, or if you're going for vigorous intensity, between 70 to 150 minutes per week. But importantly, to decrease sedentary time. And then I think very importantly, the avoidance of smoking and alcohol, and this should be an absolute no-no if you have advanced liver disease. And then we looked at the selection of medications for the treatment of comorbidities in people with MASH. So in terms of the preferred treatments for type 2 diabetes and or obesity in individuals with MASH, semaglutide is recommended. It has now received FDA approval. But in those who have type 2 diabetes with or without MASH, you can actually use pioglitazone, you can use the SGLT2 inhibitors, the DPP4 inhibitors. Just to remember that metformin, insulin, sulfonylureas can be used for treatment of type 2 diabetes, but are not for preferred treatment drugs if you have type 2 diabetes plus MASLD. And we now have 2 options in terms of actually treating individuals with MASH, the resmetirom and semaglutide with MASH to F2 fibrosis in the absence of cirrhosis in the setting of resmetirom, or MASH in adults with moderate to advanced fibrosis. And then guidance is given how you assess with NITs at 1 year for efficacy or futility. So I think we all have seen from quite a few of the presentations today that MASLD is associated with significant morbidity, all-cause and liver-related mortality. The GBD 2021 study showed that the MASLD liver-related mortality globally was 2.92 per 100,000, and for sub-Saharan Africa, 2.34, and in the MENA region, 1.56. And these GNC global consensus MASLD recommendations really aim to help provide busy clinicians with an easy and quick-to-use reference source for caring of individuals with MASLD, help to identify those at high risk, and give guidance on the optimal management of common comorbidities and liver disease with the preferred drugs. But I think ultimately we're going to need to disrupt these silos of healthcare management of communicable versus non-communicable diseases, and we need to address the costs of the therapeutics and NITs, particularly transelastography in the low and middle income countries. But ultimately, this is going to require the adoption of a multidisciplinary, multi-sectoral approach to MASLD at all levels of care to address this major public health threat. Just briefly to let you know, there are a number of surveys that we'll distribute in terms of the hepatitis B for practice for clinicians, and then one on individuals living with ALD. So we'll distribute this to everybody, and important to have data coming from Africa. Thank you.